health disparities, and reproductive health needs for women of color living with HIV. Welcome, Dr. Wright.
Good morning, everyone. Good morning. It is indeed a pleasure to be here with you today. I've known of Iris House for many, many years, and many of my patients are Iris House clients, so I really appreciate all the great work that you've been doing throughout the decades. Thank you. This is just an interesting disclosure. This long paragraph of words says that I don't receive any direct funding or any direct compensation from any drug company. So that's, I know that's often is an issue sometimes. I don't receive any direct funding. So first of all, I'd like to give thanks to one particular person, one person in particular, especially considering that Mother's Day is coming up. A woman by the name of Wright, my mother. She taught me two things that are very important that are relating to our lecture and talk today. First and foremost, that every person, especially my sisters, deserve to live and be treated with dignity and respect. Second of all, she raised me in a way that I had a nurturing and important and careful environment where I was taught to be a person I knew that I was someone. Unfortunately, everyone is not brought up that way. Everyone doesn't have the same opportunities that we have, or the opportunities that I had. I want to start off with a case. It's a patient, we call her Ms. X, actually I call her Ms. V. Often we get consults from other clients and then from other agencies to let me know that a patient is coming to see me in my OBGYN practice. Well, I got a phone call a few years ago about a patient who they described as actively using crack cocaine. Those aren't the words that they used to describe her, but that's what they described. And because of the way they described her, all of us, even in our best of intentions, we have some preconceived notions about what that patient is going to be like. Unfortunately, when she came to see me, she fit the bill of a person who was actively using crack cocaine. She was jittery, she was not making good eye contact, she had on a very unattractive wig that was turned a little to the side on her head. And so I went to talk to her and to get a good history and physical from her. She was currently pregnant. I wanted to know more about her and to get a good history so I can take care of her medically and to help to have a healthy HIV-negative baby. So I did the full history, I went to do an exam, and as I was doing the physical exam, I noticed that she had been horribly disfigured in her genital area. And immediately, my mind, because of these preconceived notions that we all often have, I thought, I bet she was smoking crack and she did something to herself and messed herself up. And so I said to her, what happened here? What happened to you that caused you to have these scars in your genital area? And she told me that she was horribly molested by her father at age 5. So there before the grace of God go I. If I had been molested by my father, or if I had all these things going on in my life as a child, who knows where I'll be today instead of standing before you right now with all these degrees behind my name talking about prevention of HIV from mother to child. So this kind of frames what the real housewives of New York are. These are the women that I take care of every single day in my practice, and these are many of the women that we care for in our practices and in our client services patient population. So at the beginning of the HIV epidemic, Ingrid mentioned that I've been doing work in preventing HIV and AIDS since the 1980s. Back then, many of us viewed HIV as a gay, white, male disease. But that has never been further from the truth. From the very beginning, HIV and AIDS had a very high prevalence amongst women, and worldwide right now, over half of all cases of HIV and AIDS are in women. In sub-Saharan Africa, over half of all cases are in women. Almost 60% of cases in sub-Saharan Africa are women who are living with HIV and AIDS. That's for a whole host of social and also physiologic reasons why that actually happens. And we'll talk about some of that today as I go through the rest of this talk. Bringing it back home to the US. These are the estimates of new infections in the United States of HIV and AIDS in 2010, so one single year. Amongst Black heterosexual women, there were 5,300 new cases of HIV in 2010 alone, amongst Black women alone. If you add to that the number of female drug users, that brings the number to over 6,000 cases of HIV amongst Black women in the United States in 1 year alone. But we're far from having this be a disease that is not affecting our populations and our communities. One of the downsides of having had this perception that HIV does not affect women and does not affect women of color is that many of us in our communities were not able to talk about it. Many of our religious leaders were afraid to talk about HIV and AIDS in our communities and in our churches because we viewed it as something that happened to other people. It didn't happen to us. I'm telling you, it's happening to us. And the reason why actually I got into doing what I do and taking care of women living with HIV and AIDS is because I was seeing more and more women in my practice that were becoming HIV infected, and many of my colleagues were saying terrible things, disparaging comments about patients who were women who were living with AIDS, and I needed to school them a little bit. And I got my schooling to go back and to school them as to what the real deal is. Most of my patients, they fall into two categories. About half of them are women who, like patient X, and had very difficult traumatic lives and livelihoods growing up. The other half are women who are working, who have jobs, who have careers. I take care of nurses, I take care of teachers, I take care of educators, I take care of administrators in my practice. AIDS does not discriminate. We discriminate. And AIDS, but when we talk about health disparities, I can't tell you how many lectures I've attended where there's a talk about health disparities. We're talking about hypertension and diabetes and cancer health disparities. HIV and AIDS is the epitome of a health disparity. These are just new diagnoses of HIV and AIDS. So again, this is representing the data I just presented a moment ago. There are over 6,000 African American women who were diagnosed with HIV and AIDS in 2011 alone. Compare that to the numbers of white and Hispanic women that were diagnosed with HIV and AIDS at the same time. Bear in mind that the African American women make up only about 12% of the US population, but they account for 64% of new diagnoses of HIV and AIDS in 2011. If that's not a health disparity, I don't know what is. I just spent the last 2.5 months working in Rwanda. And after I came back, everybody says, oh, I bet you saw a lot of HIV and AIDS cases in Rwanda. Well, actually I did, but actually I've seen more cases here in the South Bronx where I take care of my patients than I did in Rwanda. These are data that were published in the New England Journal of Medicine about 2 years ago that showed that amongst blacks in New York City, the rates of HIV and AIDS is over 3%. Which is higher than what I see in Senegal, Congo, Ethiopia, Rwanda, Burundi, Nigeria, and many other countries throughout sub-Saharan Africa. I read one study that said that if we took all African Americans in the United States and we became our own country, Africa America, we would fall high on the list of countries that are aided by PEPFAR to receive aid for treating HIV and AIDS cases because of the high prevalence rate that we have in our communities. In terms of where those infections are happening in the US, right here in our backyard, in New York and New Jersey are two of the hotspots. Fortunately, we've actually been able to make a slight dent in the new cases that are happening in New York and New Jersey over the past few years. These are the numbers from 2011, and these are the numbers from 2010. So in 2010, there are 15.5 cases per 100,000 of women diagnosed with HIV and AIDS in New York State, compared to about 15 per 100,000 cases in New Jersey. The hottest spots for new HIV and AIDS cases were occurring in the Deep South, with Florida, Georgia, Louisiana, very high on the list of new cases. In terms of where women who are living with HIV and AIDS currently in the United States, right here in good old New York State. There are 468 cases of women living with HIV and AIDS in New York State, with New Jersey 321 women per 100,000 living with HIV and AIDS. I'll draw your attention to the small print, however. District of Columbia. A true District of Columbia is a city, is not a full state, but the rates of HIV and AIDS in the District of Columbia are an embarrassment to our government and to ourselves. The rates there are the highest, actually some of the highest anywhere in the world for that matter. Also in the fine print, what's happening in the Caribbean, U.S. Virgin Islands, Puerto Rico. Extremely high rates of women living with HIV and AIDS. So until these things are brought to the light, and until we begin to talk about these things more and more openly in the public, Many people who are not working in this field and aren't living our lives don't have any idea of what's going on in the world around us. So it's up to us to be able to speak up and let our voices be heard and be known. Likewise, in terms of women who are diagnosed with AIDS, African American women are disproportionately represented in terms of new AIDS cases. And unfortunately, when it comes to deaths, there were 3,241 black women that died from complications of HIV and AIDS in 2010. 3,000 women in the United States alone in 1 year. I was mentioning my backyard and where I'm working in New York and in the South Bronx. If you were to overlay the areas where poverty is greatest in New York City, it would match line per line almost with where the largest numbers of women living with HIV and AIDS are. Northern Manhattan, South Bronx, Central Brooklyn, areas where the percentage rates of women living with HIV and AIDS are over 1.5%. And in fact, in our backyard in the South Bronx is 2.4% of all women living in our neighborhood are HIV infected. Good news, however. So the other reason why I got into doing what I do is because there's something we can do about preventing mother to child transmission of HIV. Back in the beginning, in the 1990s, before we had good antiretroviral medications to treat everybody with, the rates of transmission from mother to child were about 25%. We're happy to say that in New York State in 2010, which is the last year that we have full data for, the transmission rate was 0.7%. In Bronx, Lebanon, and in Montefiore, we have not had a positive baby born since 2008, which is amazing. And I'll go through some of the things that we do to help that happen, and things that all of you can help us with to help maintain those numbers like that. So even though we've made significant declines and improvements with the rates of mother-to-child transmission, African Americans are still disproportionately represented in the new cases of HIV and AIDS that are happening in children. The rates per 100,000 live births in black women was about 10 per 100,000 live births. Compare that to 0.1 per 100,000 live births for Caucasian women and 1.7 for Hispanic Latino women. Health disparities. In 2010, 162 children were born HIV infected in the United States. By the end of 2009, there were 9,522 children living with AIDS who required a perinatal. 63% of those children were black or African American, 22% were Hispanic, and 13% white. Remember, African Americans make up only about 12% of the US population. So what we've spent a lot of time and effort doing through New York State AIDS Institute and through our practices here in the Bronx and in Manhattan is we're looking for reasons why there are still some residual transmissions. Even though our center has done quite well, there have been other centers that have not done quite as well in decreasing their numbers. And so Gus Burkhead, who is the head of New York State AIDS Institute, back 2 years ago published a study that looked at the factors that are associated with these residual transmissions, the transmissions that are happening from mother to child, despite all of our best efforts. The biggest risk factor for mother to child transmission of HIV was a mother acquiring HIV during pregnancy. Now, that doesn't always make sense to me. That you're pregnant. You have a child, you should be protecting yourself, right? I can't tell you how many times I've had patients come to me who knew that their partner was HIV infected and were still having unprotected sex with him during pregnancy. In fact, we were just discussing this at one of the hospitals where I work. There were actually 6 cases recently of women who were exposed to an HIV positive partner during pregnancy. It's not as uncommon as you would think. Other big risk factors, inadequate prenatal care. So who has inadequate prenatal care? I'll let you think about that in a minute. I'll come back to that for 1 second. Those who were diagnosed with HIV died at the time of delivery or after a child's birth. So again, getting to those who may not have had adequate prenatal care. Illicit substance use during pregnancy is a high risk factor. And low birth weight, which is actually probably what we call a confounder, that had to do with HIV transmission to those infants. So residual transmissions are occurring amongst women who often are the hardest to reach. And that's where I need all of your help. All of our agencies need to speak to each other. We need to not be in our silos so that we can work together for those women who need the most help to get them into care, so that we can make sure that they're adequately tested, that they have prenatal care, have access to medications. You know, one of the things that I always, if you've heard me speak before, you've heard me say this before, but I always say to my medical students and residents, you know, we can e-prescribe the best medications, the most expensive medications, but if you e-prescribe a prescription and that patient has no way to pay for that copay, if they have no home to take that medication in, if they have no food to eat to take those medications with, they're not going to take the medication, and you've wasted your time. So all of us need to work together to realize what the real deal is when it comes to all of our patients and meet them where they're at. Recognize what their barriers are to care and do what we can to help them get into care and get the services that they need. The women who are transmitting HIV to their children are often unaware of their HIV infection with histories of substance abuse, mental illness, acute HIV infection, often incarceration, lack of prenatal care, and what we often call non-compliance with care. What does that mean? Well, if you ask my medical colleagues, non-compliance means, she didn't come to her appointments. What that really means is there's something going on in her life that is taking precedence over getting to her appointments. It doesn't mean that she doesn't care. And actually I've heard some of my colleagues call these patients no-care patients. It's not that she doesn't care. It's because she needs to get food. She has housing issues. She has financial issues that need to be taken care of. Perhaps her Medicaid was cut off. And this is something that we all can work on again. Actually, this is going to be my new soapbox to stand on, is doing something with having pregnant patients, especially women who living with HIV, having their Medicaid turned off. There is no reason why a patient who's coming for prenatal care and receiving HIV medications with an active prescription from me should have their Medicaid turned off. We know she's alive. Anyway, I'm digressing a little bit there. For all of us, again, we need to work together to make sure that we can provide the most that we can for our patients who are in care. Success in preventing mother-child transmission requires extensive coordination, both after birth in terms of planning and discharge. For the mother, we need to make sure there is an infectious diseases consult for the clinicians who are in the room prior to discharge to review her medications, to make sure that she's able to receive the medications that she needs so that she can be healthy long-term. Make sure she has a follow-up appointment, because the mother needs to remain healthy to take care of her children. And evaluating the need for psychosocial support. For the infant, we need to make sure that the infant is supplied with zidovudine or AZT for 6 weeks. We still use that as a part of our regimen to help for post-exposure prophylaxis for infants who are born to HIV-infected women. Making sure that there's formula available, that the patient has WIC, so that she can provide formula for her baby if she needs to have WIC. Follow-up prenatal care should be a range of pediatric care so that they can be co-managed with an experienced HIV provider, and make sure there's adequate infant diagnostic testing. So if there is, by the slim chance that an infant does become HIV infected, that baby is actually able to receive care in an appropriate and timely manner and receive the medications that they need to stay healthy. So how do we prevent mother-to-child transmission? This is an old study from the early 1990s, the classic ACTG 076 trial that looked at giving AZT to mothers antepartum, intrapartum, and postpartum, 3 time points. And we still use some variation of this for all of our patients who are delivering today. What they showed from this study is that just by giving AZT as a part of this regimen, women are 67% less likely to transmit HIV to their babies. 67% likely just with AZT alone. This is a busy slide, but the reason why I have it up there is to know that we've refined this quite a bit. We know a few things, and there's a few things that you all need to know to take back to your institutions and to your agencies. Looking at data in New York State, actually these are New York City data, overall transmission rates from 2000 to 2005 were about 2% for women who received everything. For women who received no antiretroviral medications during the pregnancy or postpartum, transmission rate was about 30%. But the key is, how do we manage those babies born to women who, for whatever reason, did not achieve or receive prenatal care? And we can make a difference. Even for babies who are born without the benefit of receiving medications prior to delivery, if that mom is identified on the labor floor or in the immediate postpartum period, providing additional medications to that baby can be effective and is safe and is effective in preventing mother-to-child transmission for those babies. In the past, what we used to give, those babies just got AZT like they did for everyone else. But if you or I had an exposure, if I had a needle stick in the operating room, I'm not going to take just AZT. I'm going to take a combination of medications for post-exposure prophylaxis. If you have an exposure and you go to the emergency room for PEP, post-exposure prophylaxis, they don't just give you one drug. These babies who have been exposed in utero to moms who did not receive medications need more than just one drug. So that's something that we can all share with our agencies and to the medical institutions that we're working on. This has not been widely adopted. It is in the federal guidelines, but everyone, as we know, everyone doesn't meet the guidelines all the time. So we can help our colleagues stay on top of the guidelines, that babies who are at high risk, have high-risk exposures do need to receive something other than just AZT. The other big category of transmissions from mother to child are women who acquire HIV during pregnancy. Acute HIV infection has an increased risk of transmission not only to mother to child, but also has increased risk of infection from person to person. The hallmark of acute HIV infection is elevated viral load with a negative or indeterminate ELISA or Western blot, or your rapid test if you're doing rapid testing at your institution. Acute HIV infection increases maternal viral load, it alters the placental's natural defenses against HIV, and it exposes the fetus to high levels of HIV, which facilitates transmission to the baby. There have been a number of studies to show that during an acute episode of HIV, persons are 1,000 times more infectious, either to the baby or to their partners, than they are during the chronic phase of the illness. So acute HIV infection really overwhelms the placenta. It overwhelms everyone's immune system to allow for the virus to be transmitted to other people more effectively. In New York State, we've shown that for perinatal transmission rates for women with acute HIV infection is about almost 40%. So for women who acquire HIV during pregnancy, their transmission rates, even in the best of all situations, is about 40%. Whereas the overall infection rate is 1.7%, and most recently we've shown it was 0.7%. Again, why does this happen? At the very beginning of an infection, your viral load goes up incredibly high. It's not uncommon to see viral loads of over 1 million infections with HIV medications. There may be some, and we know that in particular with this atazanavir has been studied quite well. We know that the dose of birth control pill given with atazanavir, the dose of birth control pill needs to be a little bit higher. So there may be some interactions with oral contraceptive pills and HIV medications. Depo-Provera, the injection, actually works very well as well. If you can tolerate the side effects, it's a good option for many patients that are taking HIV medications. There's no drug interactions for Depo-Provera. Serodiscordant couples. So one of the most frequent consults that I get in my office are serodiscordant couples, where one of the patients is HIV positive, the other patient is HIV negative, and they want to have a baby. Never underestimate anyone's desire to have a child. It is innate amongst many persons to want to have children. And my job as an obstetrician gynecologist is to do that as safely as possible. The practice that I've taken in my practice is to provide almost like harm reduction, because we know that our patients are going to try to conceive, and I want to make that conception as safe as possible and minimize the risk from mother to child and from patient to patient, from themselves and to their partners. So in the ideal world, all of our patients will be able to afford assisted reproductive technologies, infertility treatments. And the American College of OBGYN says that assisted reproductive technology should be offered to couples where one or both partners are infected with HIV. Well, I can barely afford it. I'm a doctor, assisted reproductive technologies, and many of our patients cannot afford that as well. Officially, the options are artificial insemination with intrauterine insemination, which is done in medical practice, in vitro fertilization, which is done in a medical practice, ICSI, which is intracytoplasmic sperm injection, which is incredibly expensive, sperm washing, which is only done at a few centers around the world for that matter. There's one here in New York, though. But in my practice, and keeping it real, and after discussing the clear risks and benefits of what can happen and what can't happen, We often are discussing with our patients time to ovulatory intercourse. What does that mean? If we're taking a harm reduction model, if we are trying to make our patients and their partners as safe and as healthy as possible, after having a discussion about condoms being the most effective means of preventing HIV transmission from one person to another, perhaps if you have that patient only have unprotected intercourse during the time of their menses, during the time of ovulation, not their menses, during the time of ovulation, and have them on HIV medications to lower their viral load to as low as possible, and perhaps have a discussion with them about PrEP, which I'll come back to in a minute. I'm going to go through all those steps in a minute, because this is probably one of the things that I'm asked about most in my practice. So, ovulation kits are excellent for helping a patient determine when they're ovulating. So you can purchase them over the counter. There are generic versions that are available from CVS, Walgreens, Rite Aid, any of the major pharmacies in the area. You can buy them for cheap. If you can't afford an ovulation predictor, basal body temperatures are one of the options where you measure your temperature. There's usually a slight temperature spike at the time of ovulation. These are things you can discuss with your doctor if you're trying to become pregnant and looking for the time that you're ovulating. One of the things we've known for a long time is transmission rates from heterosexual person to person is directly proportional to the viral load. And there have been several studies that have shown that by lowering a person's viral load, you're decreasing the risk of transmission from person to person. Treatment is prevention when it comes to that. The big study that proved that was the HPTN 052 study that was published a couple of years ago. They randomized stable, healthy, serodiscordant couples with CD4 counts between 350 and 550 to either start HIV medications immediately or wait to start until their CD4 count became lower. What they showed in these thousands of patients that were participating, that there was only one transmission of HIV in the cohort that was taking HIV medications from a heterosexual couple. Only one transmission that was linked to the partner. And when he did the sub-analysis of this study, they found that this one transmission actually happened right at the time that the person started taking their HIV medications. So before their viral load was decreased to undetectable. So the official numbers for this study was 96% effective in preventing transmission from person to person, but in reality it actually was 100% effective because the only one transmission that occurred before that person's viral load had a chance to become undetectable. So treatment is prevention. Also important for if you're thinking about becoming pregnant and are in a serodiscordant couple, make sure that all STDs are accounted for and treated. Include STD screening and preconception counseling. Don't forget about trichomonas and bacterial vaginosis, both of which have been associated with an increased risk of spreading HIV if you have it, and contracting HIV if you don't have it already. This is just showing that Candida, yeast infections, trichomonas, bacterial vaginosis have all been shown to increase viral shedding of HIV in the genital tract in persons who are infected with Candida, trichomonas, or bacterial vaginosis. Any sexually transmitted disease increases your risk of acquiring HIV if you don't already have it, including herpes, syphilis, chancroid, gonorrhea, chlamydia, all of them increase your risk of acquiring HIV if you don't already have it. One of the reasons why we've gotten into the quandary that we're in is because we aren't talking about the high rates of STDs in our community, and that is a fact. We need to address that. We need to speak up about the facts that people are not using condoms effectively and consistently, and they're allowing for increased risk of STDs, including HIV. So current recommendations, expert consultation for discarded couples, screening and treating for genital tract infections before attempting to conceive, artificial insemination for HIV-positive females if they have an HIV-negative partner with the option of self-insemination. What does that mean? Good old turkey baster does work. There's some movie that came out a couple of years ago where you're talking about using a turkey baster. Actually, it's effective. If there's an HIV-positive woman with an HIV-negative man, I often give my patients cups and syringes for them to use at the time of their ovulation. Have their partner ejaculate into the cup. The patient can withdraw the semen from the cup and inject it into themselves and conceive that way. It's effective. When you think about it, most of us were conceived intravaginal insemination. We weren't intrauterine inseminated. All that sperm has to do is get to the top of the vagina by the cervix, and that's the way pregnancy occurs. The other important thing is making sure the HIV positive person is on HIV medications if they're going to do something like this. Getting your viral load as low as possible. Treatment is prevention. Making sure that they're not going to infect their partner when they're having timed ovulatory intercourse. Officially, the data are insufficient to recommend PrEP at this time. However, I'll go through what we need to do about PrEP in a moment. I'm just going to skip over the comorbidities for a moment because in the interest of time. So PrEP, there may be a role for giving anti-HIV medications to persons that are HIV negative to prevent them from acquiring HIV. I know that you're going to have a session on PrEP this afternoon. I know that it is a very somewhat controversial topic for many people, but for the right patient, it is something that you can all consider, for the right patient. But important to note that data in women for PrEP have been very, very mixed. In fact, the most recent studies have not shown PrEP to be effective in women, in large part because patients were not taking it consistently. For those who have high levels of the medication that is being used for PrEP in their serum, it has been shown to be moderately effective. So this is another busy slide, but this just goes over a number of the studies that have happened. It's old, but I'll go through each of these studies in a moment to kind of clear this up with you for a little bit. So in terms of prevention of HIV in women, behavior change is not very effective. We've been trying this for a long time. We've been telling people to use condoms. We've been telling people to practice safer sex. We've been throwing condoms. I literally have been throwing condoms at patients and clients. And you know, people are still getting HIV. There's a big study that was done looking at tenofovir gel that was done in South Africa that showed a lot of promise. The Caprica study was done in South Africa, and it was 39% effective in preventing HIV acquisition in HIV-negative women, and 54% effective for those who used it consistently. Now, by no means would I ever risk my life on something that's 39% effective. No. But if you have a client or a patient who is not using condoms consistently, who needs other assistance to help them to stay safe and to stay healthy, something that may be considered, or at least that's what we thought. A follow-up study was done, it was just released 2 months ago, that showed that vaginal tenofovir actually was not effective in this cohort of women, and in large part because women were not using it consistently. The big study that you looked at Truvada for PrEP, IPREX, was 44% effective in men who have sex with men. Keep in mind, this was men who had sex with men. It was 44% effective. The issue with this also is that for those who took it consistently, the rates were over 90% effective. Over 90% effective. However, people didn't take it consistently, a big problem. TDF2 was another PrEP study that was 63% effective. FemPrEP was a study that looked specifically at women, and it was not effective. It was halted halfway through because there were equal numbers of women who were infected in the placebo arm as well as in the Truvada arm. Partners PrEP was effective. Truvada in the voice trial was not effective. And then keeping in mind treatment as prevention, the HPTN-052 trial was 96% effective. So the data are really mixed. The one thing we know is that treatment is prevention. Taking HIV medications consistently does lower your viral load and does make you less infectious to another person. The PrEP story is mixed, and actually, I apologize that I have to leave after this talk, but I have patients in the Bronx to see, and one of the patients I'm seeing today is actually a patient who conceived while on PrEP. Her partner is HIV positive. He has an undetectable viral load, taking his HIV medications consistently. I placed her on PrEP during the time that she was trying to conceive. They had timed ovulatory intercourse. I checked her for all of her STDs consistently, and I checked her for acute HIV and checked her antibodies test every month. And she is now pregnant, HIV negative, and will have an HIV negative baby because she's not HIV infected. So for the correct patient, they were very motivated. The husband came with her to all of her appointments. I was in conversation with his primary care provider about how we're going to do this together to make sure that he is healthy and she is healthy, and it can be a success story for the right patient. But for the wrong patient, I can tell you multiple times that we've had patients who are having unprotected intercourse with an HIV-positive partner, and they just simply were not able to take the medication consistently. Speaking with your patients, knowing who they are, meeting them where they're at is important if you're going to offer medications and procedures such as this. And just show them. And lastly, I was asked to add a few comments about women who have sex with women and about the transgender community when it comes to HIV. There have been many case reports for transmission of HIV from woman to woman. However, the CDC says that there are no confirmed cases of female to female transmission of HIV. However, women who have sex with women are theoretically at risk for acquiring HIV. We know that the virus is in menstrual blood. We know that from studies that I've done in my practice that the virus is in vaginal secretions. So if there were cuts in your fingers, if there are cuts and sores in your mouth, that can provide a portal of entry for the virus, even if you are having woman-on-woman sex. Keep that in mind. Other things, sexually transmitted diseases can be transmitted through sharing toys. So if you are using toys, sex toys, wrap it in a condom, because I have treated myself women who have acquired STDs from sharing sex toys. And the last thing to remember when it comes to women who have sex with women, that sexual identity does not always equate with sexual behavior. And that there are many women who identify themselves as lesbian who have from time to time had sexual relations with a man, even though that wasn't their identity. I won't go into the reasons why that may have happened. We can all imagine why those things may have happened, but keep that in mind. As far as the transgender community is concerned, the transgender community remains one of the groups at the highest risk for HIV. In 2009, persons newly identified with HIV infection was found in 2.6% of transgender women tested compared to 0.9% of males and 0.6% of females. In New York City, between 2005 and 2009, 90% of transgender persons diagnosed with HIV were Black and Hispanic. So again, another huge health disparity that we need to tackle and we need to directly address. 50% of newly diagnosed transgender women have documentation of commercial sex work, substance abuse, homelessness, incarceration, and/or sexual abuse in their medical records. So things we don't always like to talk about, but things we need to address specifically if we are going to address the problems with new cases of HIV in the transgender community. There is one meta-analysis of published studies of transgender community that showed that 27.7% of transgender women in these studies tested HIV positive. So unless we're able to target the communities where the infection rates are the highest, we're never going to do anything with getting rid of HIV in our communities. So keep this in mind as we're going forward in our practices and our day-to-day work. So prevention challenges in transgender women. One of the problems is we need to avoid making assumptions about sexual orientation and sexual behavior based on gender identity. Just because someone is male to female transgender, or just because someone is female to male transgender, doesn't necessarily mean that they're having sex that places them at high risk, or they may be having sex that places them at high risk, and they may not be disclosing that with you based on what you assume their gender identity to be. Discrimination and social stigma can hinder access to education, housing, and employment opportunities. And one of the bigger problems is actually healthcare providers, that should be healthcare providers, often have been very insensitive to the needs of transgender persons in the transgender community. And making our patients and clients feel welcome in the community, making us all recognize that everyone is a child of God and we all deserve to be treated with dignity and respect is important for us as we go about our daily lives. So just to close, this is a slide that I took. I do some work with the foundation that has clinics around the world, and these are some of our patients that were greeting me in South Africa. All of us deserve to be treated well. All of us deserve to have happy and healthy lives. They're actually singing praises, thanking all of us for the work that we're doing, and I thank all of you for the work that you're doing to help to eliminate HIV and AIDS in our communities. Thank you for your attention. There's a microphone in the middle. For either, both sides.
Hi, I have a question about one of the slides when you were talking about, for example, taking antiretrovirals while you're still pregnant. And you were showing that there was, in contrast, there was women who were taking placebos and women on ARVs. So I was just wondering about the...
Sure. That's a good, I know what you're getting at that. So that was a case of ACTG study. Wait, if you're correct me if I'm wrong about what you're asking. So the question is about using placebos for women who are taking HIV medications. So that study was done in the mid-1990s, the classic 076 study. And back then, actually, it was because of parents in our communities that were concerned about the safety of AZT given to pregnant women. That is the only reason why they had that placebo-controlled trial. We would never, ever think about doing that again. That was just the first study to show the safety of HIV medications during pregnancy, and it established that we will never go back there again.
Yes. Hi, I just want to know if HPV or that leads or would that affect women getting pregnant or their babies?
HPV has not been shown to affect the ability for anyone to get pregnant. One of the problems, however, with cervical dysplasia, when there are precancerous changes in the cervix and a patient who has to have multiple procedures done, that can change the ability to carry a pregnancy to term. So those are one of the things that we look for in women who've had multiple procedures on their cervix because of HPV. We may need to do some additional surveillance and closer watching of the pregnancies to make sure it goes to term. But otherwise, HPV does not keep you from getting pregnant. Yes?
Hi, my question is kind of one and the same with the question. As we know that before the rates started dropping for perennially infected births, a lot of children that are now 21, 18, 23 were born to infected mothers when the rates were really, really high. Are we, and I know that they're phasing out a lot of those programs for those perinatally infected children who are now having their own children. And I particularly know of one case of a young lady who has 2 children who was born HIV positive, who has 2 negative boys. My question, I guess, is there anything coming down the pipe or in place for those children that were born back in 1991 who are now at childbearing ages? How is there anything coming down the pipe for those children?
Unfortunately, the funding is really intact. All of our programs are facing budget cuts. And because we've done such a good job, we're a victim of our own success. Because we don't have as many children being born with HIV, we actually are having fewer funds being associated with perinatally infected children. However, I can tell you from experience and from the research that I've done as well, that perinatally infected young women sometimes are some of the most difficult children to manage, young women to manage, because you think about what's happened to many of them throughout their entire lives. They may have been in and out of foster care because they lost a parent to HIV and AIDS. They may have had exposures to substance abusing parents in the past. But unfortunately, funding is being cut there. We are welcoming everyone into our practices and welcoming everyone into our care. That gets to the importance of all of us working together to maintain social services, and other interventions are available for all of our patients.
Are the statistics still the same for children born with HIV, perinatally infected children, with the rates of having negative children?
They are slightly higher, not significantly higher, but slightly higher. In large part because of many of the patients that are perinatally infected were exposed to multiple different HIV medications over time and may be resistant to multiple medications, may have difficulties taking medications, so they're less likely to have an undetectable viral load at delivery. So there's a slightly higher, but not significantly higher.
Thank you.
Hi, thanks. Good morning, Dr. Wright. I just wanted to see if you could speak to holistically the community. And you mentioned housing and what that connection is, just holistically people's health. Maybe you can say something in terms of politically what we do to make sure that we have patients that we can help in terms of that, holistically, like housing, money for hospitals, those kind of things. So maybe you can speak to that individually to make sure that we
Well, I think all of us need to speak up and Yes, there was a Keep the Promise rally that was happening in Brooklyn a couple months ago, and we had a Keep the Promise rally in New York. Making sure that our administration at all levels keeps their promises to HIV and AIDS, and that, as I tell my residents, and I said, if a patient doesn't have a house to take their medications in or food to eat, to take their medications with, they're not going to take them. And until we address all of those issues that are related to all of our patients that we care for, we're not going to make a big dent in the HIV transmission rates in our communities and get the numbers down to where they should be. I mean, again, if you overlay the areas where poverty is the greatest and the areas where HIV has the highest prevalence, they overlap. There's a huge gap that we need to fill, and we need to maintain our programs as best we can. Speak up. That's the best we can do. Speak up, write letters. And you've been.
Yes, I'm wondering where are the majority of women that we can identify as being HIV positive? Is it in the hospitals or is it by community workers going out into the neighborhoods?
It's changing. Currently, for most of the past 10 years, most women would be identified when they came in pregnant. Because in New York State, we've been very forward-thinking. We've mandated offering an HIV test to all pregnant women during pregnancy. So that was where we were initially finding most HIV-positive women. Now it's shifting more. It is shifting more towards the communities and to outreach events, but also in the hospital setting as well. The Bronx has the Bronx Knows Project, where in the emergency rooms, when patients come in, it is mandatory to discuss their HIV status with them. So outreach events are working. Having every healthcare provider offer an HIV test as a part of standard of care. The U.S. Preventative Health Service, as of 2 weeks ago, finally said that everyone should be HIV tested. So hopefully they'll allow for more assurances and to make sure that HIV testing is included as a part of routine standard of care.
But there isn't any number as to where the majority of women are being identified.
Yeah, I can't give you a specific number. I can guess. Right now, I would say it's probably 50-50 between medical care facilities and in the community. But that's just a best estimate from my own experience and from reading literature. Okay.
Hi. I actually was speaking on the lady there with the perinatal infected children. I actually was a clinical research nurse since 1980 something. I'm retired now. But when you talk about the factors of HIV transmission, I think that if we don't put age as a factor, when we have everything else, we miss out on those children because it's not about their income because they don't have any. It's not about their family because they don't have any. It's about their age and their level of maturity to handle themselves. And I think if we pull that into this, we can get more of those children into care, better. I just want to make that fact.
I agree with you 100%. Thank you.